Good morning or good afternoon to all of you, and thank you so much for joining our discussion here today. We are going to really talk about what comes next for RHTP, particularly around implementation as we go forward. I'm Kathleen Nolan. I'm a senior advisor at HMA, and we're really excited to dive into this. Today, you're going to hear from several experts who are working with states and providers on RHTP initiatives. Jeff Booth is an experienced leader in hospital and health system operations. Dr. Michelle Bosworth provides clinically grounded implementation support to providers. And Juan Montanez has spent decades supporting IT and data analytics across the healthcare spectrum. Our plan for today's discussion is to focus on the implementation of RHTP grant dollars in provider organizations and in communities across the country. For several months now, we have all been collectively focused on grant applications. States have put out dozens of opportunities, and awarded funds have now begun to flow. But in our view, that's the easy part. Now the hard work really begins. So our agenda today is to catch us up on where we are and to begin to look forward. We'll talk about the key expectations and objectives the federal government and states have. And then we want to share our vision for how we can create lasting change by building implementation plans and weaving initiatives together across the care continuum. And we also need to fully optimize the technology investments and operational reforms funded with the RHTP dollars. A couple of housekeeping items before we dive in. Throughout, we do welcome questions and comments as we go along. During the presentation, please do put your thoughts, your questions, your perspectives in the Q&A, which there is a button at the bottom of your screen. At the end, we will certainly save time for us to pull those questions forward and to get some feedback from our speakers. One other housekeeping issue, all registered participants will receive the slides and recording after the call. So before I turn it over to our speakers, let's level set. As you all know, this is a large 5-year grant program focused on rural residents and communities. But there are no guarantees that the money will continue to flow without demonstrated progress, even in the short term. While this can be scary to hear, we think that providers and communities that lean into the key themes of collaboration, sustainability, innovation, and technology, and that do so in a coherent way, can be successful. So that's really what we want to discuss here today, is how to make that a reality and how we can help you think this through. So Jeff, I'm going to turn it over to you to take us forward.
Thank you, Kathleen, and please let me add my welcome to everybody. Good morning, good afternoon, and thank you for joining us. I'm going to share 3 slides that kind of set the table for this discussion. The content in these slides you're probably somewhat familiar with, or very familiar with, but on the next slide, these are the 8 requirements of RHTP, and it's word for word from HR 1 language that was passed in July of 2025. And I would note that when you look at the first 2, those are the core objectives, right? To improve access to care for all citizens in these rural communities, and over time to improve outcomes, healthcare outcomes for all of these citizens. If you look at the other 6, I view those as, methods for achieving that. Very important initiatives around technology. Number 4 is around collaboration, which, as Kathleen mentioned, is one of the key themes in RHTP. And I'll talk a little bit later around its collaboration within your community as well as outside your community with tertiaries or academics. Number 5 is around workforce. Number 6 talks about technology again. And really, when you look at the wording in 7 and 8, it's about identifying the root causes for the financial stress that has been on rural hospitals and providers for a long time. So a reminder that RHTP is a 5-year program. Funds will cease coming forward after 5 years. So one of the things we're really going to talk about is how do you build in sustainability, that platform from the beginning. Very key. So again, these are the 8 requirements of RHTP. On the next slide, the HR1 language also requires evidence that recipients and users of RHTP funds use it for at least three of the following. So as you look down here, I would imagine most communities will use it for more than three, but I bolded certain words just so we can understand, a core focus: chronic disease, payment models, technology solutions, workforce and training, again, technology. Letter G talks about prevention, right? So when we talk about chronic disease, and Michelle's going to talk about that in a little bit, it's about chronic disease prevention, monitoring, and management. H is around behavioral health, and I is around payment models. So individual communities will have to report to the state, which will then have to report to CMS that the monies have been used for at least three of these uses. So I just wanted to lay that out. On the next slide, on slide 9, our HMAIS group reviewed all applications that were submitted by the 50 states. All 50 states submitted their applications by the deadline of November 5th, 2025. And this is an output of the analysis of what those applications included from a theme or topic perspective. So a couple quick comments on this. We put a lot of detail on here and a couple other slides. I know that's violating PowerPoint presentation, but you're going to receive these slides, so I wanted you to have this information. But just a couple quick comments, and then I'll ask Juan to jump in. If you look at the blue box on the bottom, there are a lot of mentions around technology, leveraging technology to improve access, to improve care, to improve reporting, so on and so forth. And then obviously, chronic disease prevention, monitoring, and management is key. And one theme that we'll talk about as we move forward around that is we're talking about improving not just the health care model in these communities, but over time improving the health status of the citizens in those communities. So Juan, would you care to add some flavor to that, sir?
Sure, Jeff, and good morning, good afternoon, everybody. Technology is clearly permeating every one of the rural health transformation plan applications from states, in part because the feds kind of hinted that they wanted to see a lot of technology-driven innovation in those applications, but also because, let's face it, I mean, technology is an essential enabler of a lot of the other initiatives that are built into these rural health transformation plan proposals. So not surprisingly, you see a lot of emphasis on just core health IT functionality, electronic health record, care management, health information exchange, but you also see telehealth, you see remote patient monitoring, you see technology that's designed to support different modalities of care beyond just the documentation and the flow of information, technology that you need to really maximize the ability to serve the population in rural communities. So we're going to talk about this some more later in the session, but it is not surprising that so much of the emphasis in all of these planning applications was on investments in technology, which need to be sustainable and need to be investments that have meaningful, documentable impacts. More on that to come. Back to you, Jeff.
Yeah, and I'll actually kind of say a few comments too, if I may. If we can go back one slide, from a clinical perspective, what really stands out to me in this analysis of what the states are planning to do is that states are not viewing workforce and technology and access and chronic disease prevention and management as really, they're not doing it as separate challenges. States are recognizing that chronic disease is one of the primary drivers of preventable morbidity, mortality, utilization, and cost in rural communities. And that technology, as Juan's talking about, can help create new ways to identify risk earlier, monitor patients more effectively, and keep people connected to care between visits. The opportunity for states is really now to move from talking about these themes that we're seeing in the applications to implementing them as an integrated care delivery strategy. So as we move from discussing requirements and implementation strategies into execution, it's worth pausing to define what success actually looks like. So too often, transformation efforts become focused on implementing activities rather than achieving outcomes. RHTP gives us a unique opportunity to keep the focus where it belongs, on improving access, improving health outcomes, and creating sustainable healthcare models for rural communities. Success for rural communities and for each state as a whole is not about the volume of initiatives, but the value and impact of those coordinated initiatives in the rural communities and across the state. Success will be measured by whether more people are connected to care, whether physicians and advanced practice professionals and their care teams are better equipped to meet community needs, and whether rural healthcare systems are stronger and more sustainable 5, 10, 15 years from now. And with that in mind, let's look at the slide that we have up right now in terms of what success looks like from 3 different lenses: the patient perspective, the rural provider perspective, and the state healthcare system perspective. So when we think about success, I think it's really important to start with who this program is ultimately meant to serve. It's the rural patients and their communities. From the patient perspective, success means healthcare becomes easier to access, easier to navigate, and it's closer to home. Patients with chronic conditions are either prevented to begin with or identified earlier, monitored more effectively, and supported before they even experience a crisis. They are no longer forced to choose between getting care and traveling long distances because the care model is designed to meet them right where they're at. This aligns directly with RHTP's focus on improving access, prevention, and chronic disease management. Now, from the rural provider perspective, success means clinicians and care teams have the tools, the information, the partnerships that they need to practice at the top of their license. I'm actually working with some rural providers right now to implement depression screening in their practice as part of a program that's being implemented by the state. These providers historically haven't even wanted to ask the question as to whether or not their patients are experiencing depression because they had no one to refer them to, no one to provide counseling, no one to help with psychiatric medication management. They themselves were equipped with the tools and supports to fully serve their population. So who suffers? The patients, their families, the communities ultimately. And what if that rural health provider experiences depression themselves? The crippling to the community is exponential. Rural providers remain the center of care delivery in their communities, and they need access to specialty expertise, care coordination resources, workforce supports, and sustainable operating models that reduce burden and improve outcomes. Finally, from the state health system perspective, success is about creating lasting transformation, not isolated projects. It means using RHTP investments to build regional collaborations, align the technology and care delivery strategies, and improve measurable outcomes. You want to strengthen rural provider sustainability and their ability to care for their rural patients and create a foundation that continues long after the 5-year funding period ends. The ultimate goal is a stronger, more connected rural healthcare ecosystem that consistently improves both access and health outcomes over time. And that naturally brings us to the next question. What capabilities and infrastructure are needed to make that vision possible? And that's where technology becomes a critical enabler of these clinical and operational goals. Next slide, please.
Thank you, Michelle. So, 5 major impacts that technology can deliver to meet the vision that Michelle just outlined. We clearly need better access to care, and technology is critical to achieve that, whether it's through better electronic health records to be able to access information about a patient's ideally entire situation, as Michelle described, physical, behavioral, social, as well as being able to use technology to improve collaboration, which sometimes needs to be in real time between providers, electronic consults, discussing a case with an interdisciplinary team. All of that is essentially enabled by technology. You can't do it with paper anymore. You can't do it with pigeons. You do need technology to provide that kind of connectivity. Underlying all that is the ability for this information to flow more effectively. Now, historically, health information has never flown particularly easily between systems. We have invested in health information exchanges. We have been promised by the vendors of electronic health records that their systems inherently interoperate with other systems that are also supplied by that vendor. So we have an environment where still there are challenges getting systems to talk to each other. Progress has been made in establishing standards, but some investments need to be made, let's face it, to enable greater interoperability across systems so that the information that you're actually receiving or able to receive in real time, if you need it in real time, is current, is readily available, obviously secure, which we'll get to the last tower here. But you got to have that unfettered access to information. You need to, because these rural providers are already overwhelmed as it is. They don't have armies of people that can support billing and scheduling and operations and everything else. So let's deploy technology smartly to improve their productivity. Here's where artificial intelligence, properly deployed, can potentially be transformational in the ability of providers to be more productive and not have to be so bogged down by administrative gobbledygook and be able to focus more on the actual delivery of care. Then you get to data and making data much more easy to analyze, digest, process, extract meaningful insights out of it. And here again, artificial intelligence could be transformational in the ability to help providers distill so much information that they're so often bombarded with and be able to get to a potential diagnosis, a potential treatment plan, and project that outcomes more effectively. So the power of AI could also be of significant transformational impact when it comes to the ability of providers to make something out of the information, not just get to it, but be able to use it. And then lastly, because we can't forget this, and this applies to all deployments of technology, there has to be security, especially in these times when people are concerned legitimately about hacks and ransomware and all this other business, nefarious business. There has to be a very important focus placed on cybersecurity. We still have to remember that this information is highly confidential, and privacy, HIPAA, none of that for CFR Part 2, none of that has gone away. We want more ready access to data, but we still got to make sure that it's properly secured and only those who have the need to access it can get to it. And resilience, which goes back to also to the notion of sustainability. These funds, we know, are not going to be here forever. They're meant to jumpstart investments. They're meant to support investments for a period of time, but then there is the expectation, and it's in the federal guidance, that these investments will have sustainability, that once these funds end, that there'll be a way to keep these investments alive. You know, a lot of money was spent after the High Tech Act, $20 billion. Not all of it was accessible to certain providers of behavioral health providers, which we know is something that can be addressed to some degree with RHTP funding. But there have been challenges, we know, with those funds. Once they expired, could providers actually continue to invest in these very expensive systems? This, in a way, is an opportunity to rectify that, with the focus being on rural providers. But all of these are important considerations. Improving access to care through technology, improving the ability of these systems to talk to each other so that the data can get to the providers in a more timely, efficient way, reducing the administrative burden that providers, particularly in rural parts of the country, face, making that information that's accessible easier to digest, and making sure that there's security throughout the whole process. Back to you, Jeff.
Thank you. So far we've talked a little bit about the background of our HTP, and then thank you, Michelle and Juan, for laying out the vision, right? What's the vision for these communities as you use these funds to improve the healthcare model and the health status of the communities? So what I want to do now is kind of share where we are when we look at the journey starting last July of 25 to where we are now. We've all been through this together, right? States applied to CMS. All 50 states applied by the deadline of November 5th last year. All states were awarded a varying levels of money. States then began at different paces to create the framework on how they're going to roll this out. Some states have regions, subregions, collaboration structures, and so on and so forth. I will tell you, it varies greatly across the states across this country. And then as the states started to share the RFPs and the process for applying, sub-grantees have begun to apply. In some states, that process has not yet started, even though we're facing a deadline in about 6 weeks for that to have to happen. So that's the journey of where we've been. So if we can show the next 4 phases, please. This is what we're going to talk about in our remaining time today, when we talk about the phases of implementation, planning, and execution. The first step is the need to document baseline performance, and I'll come back and talk about that in a minute. Then creating those regional collaboratives, partnerships, whether both internal in the community, but regional as well. And I'm fully aware that a lot of communities have already gone down this path and done some great work to create those relationships. Then there's the actual implementation of the tactical initiatives and the tracking and refinement. So that's kind of the framework of how we view this journey, what we've been through so far, and what's going to come over the next year or 2 or 3. So on the next slide, next couple slides, we're going to talk about how we map initiatives to objectives. And I know this has a lot of words, but we did this because this will be a takeaway slide. So just to kind of frame for you the purpose of this slide, the first column, initiative, those are representative examples of initiative categories, the first 4. And the bottom one, we put on there intentionally citizen connectivity. Really key that whatever initiatives are deployed in an integrated manner, we're talking about improving the connectivity with citizens who are already connected and connecting with citizens who are not yet connected, which is addressed by the fact that data shows disparities of care and both incidence rate, mortality rate, and heart disease and cancer and so forth. Those are things we need to impact. The second column has a lot of detail. I won't go into that. The key on columns 3 and 4 really is to emphasize the overlap areas. So if you look at that, you can see that primary care, telehealth, workforce kind of flow across all these. And then the local players involved, you can see it's pretty extensive. So the takeaway from this slide is that we recommend that you, as you begin the implementation phase of this, that you plan and implement tactical initiatives in an integrated manner, not as individual initiatives that ultimately come together later, but implementing in an integrated manner can increase pace to success and the degree of success, both from impact on the citizens as well as impact on the providers in the community. So on the next slide, I'm going to introduce this slide real quick and then turn it over to Michelle. The first column is called Initiatives to Expand Connection, like I just talked about. These are 4 representative initiatives, but the theme here is that think about the tactical initiatives that you as a rural community have been given the opportunity to implement, and think about designing and implementing them in a coordinated manner. And with that, I'll turn it over to Michelle.
Thanks, Joe. So let me bring this to life, from a clinical perspective. When we think about chronic disease in rural communities, the reality is that most poor outcomes are not caused by a lack of treatment options. They're caused by delays in identification, inconsistent monitoring, missed follow-up, and fragmented movement through the healthcare system. That's why it's important to view chronic disease management as a coordinated care model rather than a standalone initiative. Looking at this example on the screen, each component serves a different clinical purpose. Mobile health, EMS, telehealth, and remote patient monitoring create additional points of connection with individuals who may not otherwise access care. So rural hospitals, clinics, community-based primary care providers, and specialty providers form that clinical backbone of ongoing management. Then transportation, workforce, and telehealth initiatives help remove barriers that often prevent patients from getting the care they need when they need it. Clinically, the goal is to move from episodic care to proactive care. Instead of waiting for a patient with uncontrolled diabetes or heart failure to present in crisis, we instead create multiple opportunities to identify the risk earlier, monitor them between visits, intervene when conditions begin to worsen, and coordinate care across the continuum. And the ultimate goal is to prevent chronic disease from occurring in the first place. So ultimately, success is measured by fewer avoidable hospitalizations, fewer ED visits, better control or absence altogether of chronic conditions, and healthier rural populations that remain connected to care over time. So speaking of connected care, let's think about maternal health on the next slide. So using maternal health as an example, this slide illustrates how multiple RHTP initiatives can work together to create a clinically integrated model of care rather than a series of just standalone projects or initiatives. The fundamental goal is to identify maternal risk early and ensure that women receive the right level of care at the right time and in the right setting. Most prenatal and postpartum care can and should remain close to home through rural clinics, FQs, rural health clinics, and local hospitals. However, when higher risk conditions are identified, such as hypertension, diabetes, any kind of behavioral health concerns, substance use disorders, or complex obstetric complications, patients need a reliable pathway to specialty support. In this model, the maternal care continuum hub functions as the coordinating center connecting rural providers with maternal fetal medicine specialists, tertiary care centers, and NICU resources. Telehealth, remote patient monitoring, specialist consultation extend clinical expertise into the rural communities and allow providers to intervene earlier before complications escalate. So this is not simply just a referral model. It is a shared care model. Rural providers remain active participants in care delivery while specialty teams support management of the higher risk patients and guide escalation when appropriate. EMS transport networks, community health workers, doulas, home visiting services, they all just further strengthen that continuity across the prenatal, delivery, and postpartum periods. From a clinical perspective, success is measured by whether we can reduce preventable maternal morbidity, improve management of high-risk pregnancies, strengthen that postpartum follow-up, and ensure that every rural patient has access to risk-appropriate care, regardless of their geography. Next slide, please. So in this slide, we'll look at behavioral health as another example of what we mean by designing initiatives in a coordinated manner. One of the biggest challenges in rural healthcare is that behavioral health needs are common, but behavioral health resources are limited. Patients frequently present first to primary care, AD visits, community clinics, mobile health teams, or EMS. Unfortunately, many communities simply do not have psychiatrists, psychologists, licensed counselors, perinatal CHWs, or other behavioral health specialists to meet the demand. The collaborative care model shown here is designed to address that challenge. Rather than relying on direct access to a psychiatrist for every patient, this model creates a team-based approach that keeps primary care at the center of care delivery. The primary care provider remains the patient's ongoing clinician, supported by a behavioral health care manager and a psychiatric consultant. Telehealth further expands the psychiatrist's reach, so specialty expertise can be brought into rural communities without requiring every patient to travel long distances. What makes this an RHTP model rather than simply a behavioral health program is the way multiple initiatives are working together. Workforce investments help develop care managers and behavioral health capacity. Telehealth provides access to the psychiatric expertise. Mobile health, in-home care, and EMS create additional pathways to identify and engage patients who might otherwise never enter treatment. And of course, technology and registries allow patients to be tracked proactively rather than relying on crisis-driven care. Clinically, the goal is earlier identification, timely treatment, better follow-up, and improved continuity of care. When behavioral health conditions are identified and managed earlier, we often see improvements in chronic disease management, lower ED utilization, fewer avoidable hospitalizations, and better overall health outcomes. Next slide, please. And I'll pass it to Juan.
Thank you, Michelle. And I'll be pretty brief on this one. So this is meant to show how different modalities of technology or deployments of technology can further all the goals that we have been talking about during the course of this session. And this is just trying to bring more specificity to that. On the left-hand side of the diagram, you see the deployment of technology that truly directly supports the delivery of care at the point of care. Telehealth, obviously, we're trying to make more investments in that. Increasing mobility so that we're actually bringing care to the people, not expecting people to come to a point of care. So mobile clinics, home-based care through the use of remote patient monitoring and other technologies that are at the home. And then agentic AI, which really supports all of the above, the ability to go beyond just using AI to support what goes on within a site, helping a provider. But here we're talking about AI actually serving as an extension of the provider through the ability to exchange information with a patient or even query a patient, which we're seeing today. I think all of us have already experienced to some degree how an AI agent is actually talking to you in a contact center. And sometimes you don't even know that it's an AI agent that's actually doing that. And the evolution of that technology is just accelerating. So that's the left hand of the diagram. On the right hand side of the diagram, you see the use of technology for improving the access to information, the ability for providers to collaborate, and the ability for providers to leverage that data in a more effective way. So you're seeing in multiple states the use of RHTP funds to establish these data atlases, these repositories of data that are focused on collecting this comprehensive view of a rural patient. Again, looking at their physical, behavioral, and social circumstances. These care management platforms that are designed to enable that collaboration in real time so that providers can look at an individual's presentation, case complexity, and so forth, develop care plans in real time, and administer those over time, assign tasks to different providers within different workflows, and then using AI to really beef up the ability of providers to make something out of data. So these are all critical ways in which technology can be deployed. And on that box on the right-hand side there, you see how states are looking to use these funds by pooling resources, by having providers collaborate. Again, we're trying to stretch these dollars. So where it makes sense for providers to come together and make joint investments in either a piece of technology or in a resource that can help them deploy and manage that technology, that makes a lot of sense. Joint purchasing along the same thread there, and then tailor technical assistance, where organizations, frankly, like ours and others, are actually engaging providers to help them make the right decisions about technology and also deploy those technologies in the most effective way and using the technology to drive improvements in care workflows. Back to Jeff.
Okay, thank you, Juan. So to wrap that up, when we talk about planning to integrate initiatives in a coordinated manner, there are four key benefits to doing that. One, you achieve a greater degree of effectiveness of your implementation, achieving your objectives, greater degree of success. You can improve your pace of progress, and you can create a more sustainable platform for going forward. So again, integration of implementation, planning them in a coordinated manner is very important. So this is just a reminder that, we're going to talk a little bit now about these next four phases. So if we shift to the next slide, please. Again, it has a lot of words on it, but I wanted to show this just to show you kind of the magnitude of the effort that will be needed to document operational, financial, clinical, and community-based factors that you'll have to document and track over time. The amount of effort that it will take to both develop, implement, and manage these collaborative structures, both in your community as well as externally with, say, academics or tertiary care systems. The PMO, the number 7 there, I'm going to talk about a little more, but it should have a lot of functions in it to manage this complex process. Anytime change is implemented in any part of the provider sector, it's difficult. When you talk about implementing change of this magnitude across a multiple number of stakeholders, you need to have a very strong kind of management structure to manage it and report on it, to resolve issues and so forth. And then we'll talk a little bit about tracking and refinement. So on the next slide, we ask the question, what is CMS looking for, right? So remember, this is all relative. When they've been clear in their messaging going back to, fall of last year, that they're going to look at this in a relative manner amongst states as to who has the best plan, who's making the best progress, who's sticking closest to their plan. And I would make a comment on progress. Progress is the word I use, not achievement. So, CMS has been relatively clear that they're looking for you to achieve progress towards goals. So start these initiatives, begin to develop that advanced chronic disease prevention, monitoring, and management program, even if it continues to need to be built out over the next year or so. So start things early, coordinate among them. These things, look for some quick wins. There are certainly some quick wins, particularly in a rural hospital in the ED for telehealth for stroke or cardiac. There may be some quick wins that take a few months to implement with an academic or tertiary where you're going to improve outcomes and care and reduce costs and so forth. So look for those quick wins, and then demonstrate your plans for integrating the initiatives. Because remember, we talked about there are 2 objectives: improve access and care, enabled by the other 6. Okay, so look for ways to demonstrate to your state and CMS that you're integrating these to achieve those objectives. So on the next slide, we talk a little bit about the governance model. It will be and is required by this program that you will need to develop, implement, and manage a governance model at the community level that coordinates activities, ensures accountability, and balances focus again on improving the healthcare model, but also over time improving the health status of the communities, of the citizens in the community, excuse me. Why is it critical? Because we're talking about coordination across multiple stakeholders, diverse types of stakeholders. We're talking about coordinating at the local, state, federal level, ultimately, and the need to create sustainable, scalable solutions. That's actually spoken to in the HR1 language. It is key that things need to be sustainable and scalable, and the states are going to focus on that. So governance model is very important. Part of the governance model is on the next slide, which is a PMO. And this is a good takeaway slide. I'm not going to go through all of it, but really just to share the comprehensive nature of what you will need to manage this process. So there's 6 areas, right? Documenting current state data we talked about. We recommend developing at least a 2-year action plan that defines how these things will be integrated in a coordinated manner or implemented in a coordinated manner. Communication plan, we haven't spoken to that. Very important. This is going to be tremendous change in your communities. So it's good to get ahead of that and communicate with all the state schools and government and so forth and businesses. What's the objective and why? Because many of those other stakeholders can get involved and should get involved. You'll need an issue resolution process because there's going to be problems. Anytime you start to implement change in the provider sector, there will be barriers, whether those are technological barriers, process barriers, whatever it may be. So that's the kind of just what this slide here is supposed to represent. I won't talk any more about it, but I think it's a good takeaway slide. On the next slide, we'll talk a little bit about monitoring and reporting, which is a requirement, as we mentioned, from the local communities to the state, and then the state to CMS. So far, CMS has messaged they're going to look at things on a quarterly basis. We'll see how that plays out. There obviously will be annual assessments and reports that the CMS will use to determine whether they claw back money, reduce what you get next year, whatever it may be. You're going to want to align to award terms, specific to your particular state, documenting milestones and so forth. Timeliness affects funding, right? So again, CMS will look at this probably from a relative perspective. Some states are going to move at a greater pace. Some others won't move at such a pace. that will affect funding in years 2 and 3 and beyond. So we encourage you to remember not to go too fast, but remember about time limits. Governance implication, very important. Juan, would you like to share some thoughts on that? Because it really does have a heavy technology data component to it.
Sure. And we were chatting about it right before we kicked off the webinar. I mean, the figuring out what data needs to be collected, not just for the purposes of managing whatever program is being implemented, but given all of the strings attached to these funds, and we got to recognize that reporting that has to go to the states, reporting that has to go to the feds, reporting that's frankly needed internally to make sure the program is being run effectively and it's actually yielding the benefits that were expected. The identification of what data is needed, how it needs to be collected, transformed, and reported on, it's almost a project in and of itself. So within all of these initiatives that are tied to RHTPs in states, we highly recommend that there are strong data analyst, architects types embedded in those projects that can help figure all of this data stuff out. That is going to be a critical part of all of these projects. Thank you, Jeff.
Yeah, thank you, Juan. And then the last thing I want to talk about is sustainability. We've mentioned it a number of times. It's going to be key, but I encourage communities to really focus on this from the start. It's about integrating into your state's healthcare strategy. Each state has a slightly different strategy and approach to this. Leadership, both clinical and administrative, will be key as you collaborate, increase buy-in over time, share successes, which will be really important. Defining those requirements for monitoring and reporting, we've talked about that. Infrastructure is very important. I mentioned again the communication plan. This is going to be a lot of change for your community. So, it's getting ahead of that communication plan as far as what the objectives are, where we are in progress, and how we're handling any issues, and then obviously the benefit to the citizens. You want to share that in an open manner. And then the last box there is really important. I want to go back to something we said a couple times, that the objective of this program is not just to improve the healthcare model. We need to do that, and we will do that. But we need to also focus on improving the health status over time of citizens in these communities, reducing disparities of care, both incident rate and outcome, particularly in chronic disease. So that's sustainability. Next slide, please. Or we to
I think I'm going to pick this one up for me, Jeff. And I think as I've been listening to my colleagues here and seeing some of the questions coming through, I think this has been a lot that we've sent your way. And I think one of the things that I want to really recognize is we've been talking about integration and pulling the threads together, but we really want to recognize it is not easy. This is a really challenging component, in part because a lot of these initiatives have been funded as sort of standalone. We've seen a lot of grant applications for implement an EMS or a mobile unit, do telehealth. And what we're envisioning and what we know you all want to accomplish is utilizing those opportunities in an integrated fashion. So what we were hoping to do today, and we want to continue the conversation with you, is really try to clarify, we do think it's possible. It is out there. And the way to think about these is to build the kind of integration, project management, data collection into each one of your funding opportunities and into your overall strategy. And that's really what we're hoping to support you in thinking through today. So the path is to really try to bring all these pieces together as we've been talking about. And how do you do that? Well, really the first part is you have to have, I'll call it the theory of the case, right? You have to have the bigger picture in mind and build an implementation plan that weaves opportunities, initiatives, funding together in an integrated way. And so it's really important to take the time to think about the kinds of outcomes that Michelle was describing and build your initiatives with those things in mind. As Jeff mentioned, you really do have, this is a focus on in changing the outcomes for people living in rural communities, particularly around more access to prevention, more timely prevention, and more timely chronic disease interventions. And so those are really the major focus of many of the opportunities that are out there. The sustainability plan, I think, is something that we all struggle with. I want to spend a little bit of time. I know there's been some questions that have come in talking about the sustainability and the data to demonstrate sustainability and to get ready for it. And then really about the connectivity. The end result of all of this funding is for rural residents to have regular interactions, more regular interactions with the healthcare system at the right time. And so that connectivity is a really key outcome to be measuring. And then finally, we've all been rushing. That was where I started, right? We've been seeing opportunities coming out and we're trying to take our best advantage of them. But pacing yourself, thinking about the end results is really a key component to that. So we're hoping we've given you a few thoughts on that today, and we wanted to dive into questions. Before we do that, anything that I missed in my summary here from my colleagues, anything you want to reiterate or emphasize?
I think that was a great summary.
Thank you. Yeah.
Terrific. All right. So some of the questions that we've been seeing, one of the issues that has come out was we've talked about a lot about how we use data or demonstrate performance, how we can keep the money and the progress going with data. Can one of you or all of you sort of speak to how we should be thinking about this? And one of the questions that came up in the Q&A was also, how do we think about baseline? So if we're talking about progress, how do we think about baselining? How do we think about setting our benchmarks in the beginning? So any comments from any of you about how to think about data elements for showing progress and about baselines?
I could start and then we can pick it up from there. And I did respond to the question in writing too. So obviously this is not an easy thing in some states because of the fragmentation of data, but given the push to be able to measure, and yes, we would need to do some quantitative measuring of the impacts of these initiatives across all the different dimensions that we can think of: cost, utilization, quality, health status, and outcomes. That baseline needs to be established with the best available data that's out there, whether that data lives in a state-run health registry or an all-payer claims database, whatever the sources might be that are credible, that baseline really does need to be established. That will be right off the bat. From there, then all of these initiatives, and this goes back to the issue that we discussed around data in before, each of these initiatives has to have the ability to generate that data that can be used to then measure changes in those indicators. So if we have established a cost of care baseline for a population that's being served by a particular program, we have to have the ability to then track how cost of care is changing for that same population. Again, in a pretty scientific way, so that we can then defensively say that this initiative has yielded these quantifiable and in some cases monetizable benefits. That doesn't mean that we forget about doing patient surveying or provider surveying and looking at the experience of care or how patients feel about how well they're doing, or providers and how well they're doing, to the point that Michelle mentioned about how you have some providers out there that might be as depressed or more depressed than their own patients because they don't have, access to resources. All of that has to be measured too. And that there is a qualitative component to that measurement, to that evaluation. But based on what the feds are expecting and based on what we're seeing states expecting, a lot of what needs to be done to document the impact of these initiatives has to be quantifiable. And that's why data is so important.
Yeah, just to
Michelle,
add,
go ahead, Jeff, please.
I'm sorry.
Yep.
Just to add a comment, and then I was going to ask Michelle to add to what I say, is that a starting point is the states had to submit data to CMS. So for example, Michelle, I'll use a maternal care model example. If a state put forward to CMS that they were going to design and implement a maternal care model, there are very distinct clinical data points that you would need to document from a current state and seek to improve In an application to CMS, the states were required to set targets for that improvement. So that would not be the entire universe of data that you'd have to look at, but it's a really good starting point. Michelle?
Yeah, no, Jeff, you're exactly right. And so the most important, I think, concept is a population health concept, right? So first you have to seek to understand your population. So what is your population's current health statistics? What are your current outcomes? What are the current processes that are in place that are currently measured that are impacting those outcomes? In states applications, yes, there was a huge, but a quick push to create those applications and understanding what the state's population health actually is. Now that data probably isn't perfect. And as we're actually thinking about true health outcomes in the rural population, the data may need to be changed in terms of improved. Well, we need to look a little bit more at this. Are these truly the root causes? Are these true process measures that are going to impact outcomes? So there's going to be a lot of, I think, data sophistication and maturity within the RHT program so that we can actually understand that what the initiatives are doing are truly impacting the outcomes that we're looking for.
Another thing to think about is as we look at data in rural counties across the country, it's quite often that we see clear picture of the disparity of care. When you look at the incident rate and mortality rate, for example, for colon cancer or breast cancer in that community versus a state average or a national average, you can see a delta that it just says, hey, we need to address that. So that is most likely driven by that lack of connectivity with citizens who aren't getting that screening, those screenings for colon and breast cancer early enough. So when they do end up presenting for care in the ED or wherever, it's later stage, which is not good for the patient, but it's also more costly to the system and so on and so forth. So obviously the most important factor are the citizens and the patient, but I would recommend taking a look at that data to help target your specific initiative. You can even do it down to the neighborhood level or zip code level if you need to target these initiatives when you think about deploying, for example, EMS in-home care, in-home models that will enable chronic disease prevention, monitoring, and management. Where do you want to go with that? Well, you want to go where there's the biggest need, right? The biggest data validated disparity of care to help these folks get connected in and be treated earlier on in their disease journey.
I'm going to weave together a couple of your comments and some questions that have come in and continue on the data aspects, including data governance, but also the availability of data and how providers and communities that are receiving grants might leverage data that they do not own. And I would toss on the pile, just because I want to, the use of AI in this environment. And do you all have any advice for how communities coming to this get access to data that they don't have access to right now, including partnerships, et cetera, data governance? And then is there an AI aspect we should be thinking about as we look at this concept? Juan, I'm going to start with you.
Sure. I mean, the state has to facilitate, in my opinion. I mean, they're the ones that have the most ability to, because there was a question, for example, about how do we get data from NCOs? Well, the MCOs have contracts with the state. The state has to require that data be liberated and to not let the MCOs make the argument that data is proprietary, because it really isn't. I mean, ultimately, the provider needs it so that they can do their job and they can actually meet the requirements of their own agreements that they have with the MCO. So the state has to be the broker and the facilitator of this improved access to information across the entire ecosystem. It starts there. When it comes to the AI, the potential is almost limitless. There have to be obviously guardrails placed on how AI assistants in particular are used so that we're not putting data in an AI assistant that should not be in an AI assistant, particularly when it comes to PHI, but those guardrails can be put in place governance of AI use has to be a part of the conversation. It has to be part of the discussions about how AI is deployed, but nothing that cannot be overcome. The long and short of it is when it comes to AI, you should use it, you should embrace it. It just has to be done the right way.
One other thing to think about is that there are predictive analytics models out there that can be deployed to look at current care patterns from a particular rural community by disease state or so forth, and then look at the population and other data points to predict in a range estimate manner, where the incident rate will be as far as chronic disease, heart disease, or cancer, whatever it may be. So deploying those may be helpful to really target your strategies as you move into these communities.
As you were saying that, Jeff, I was thinking back to Michelle's comment earlier about this is not about volume. This is about value. This is about value to communities in, not just how many more people, count, but really how many more are getting what they need from the system. And so I think using predictive modeling or AI or other things can help people understand how to get to that value question, how to not just be about, I can count now there are more physicians who are using an EMR in their office, but in fact, we have more people engaging with the healthcare system because they have greater efficiency. The value is really the end result of all of these efforts for our communities. I want to end on the note that we've all been in programs here. You mentioned high tech, Juan, earlier in our presentation. These are real-time learning opportunities, shall we say it that way. We are all in this boat. We are all trying to figure it out, including the federal agencies who are instituting and implementing HR1 to the states, to the providers and communities. It's being done in lots of different ways. There are lots of different topics that are being covered in these funded initiatives. Is it behavioral health or is it maternal care or is it something else? The bottom line is we're all trying to accomplish very similar outcomes. We're trying to drive towards an outcome that is shared across communities and across states. So we all have to learn from each other, and it has to be real-time learning. And so at HMA, we've been working with a lot of providers. We're trying to gather our best lessons and share them. We hope you've been able to pick up a few here today because this is a huge challenge and we're all in this boat together. And we're really excited about what it can bring, but recognize the difficulties that are there and the complexity of this topic. So we want to thank you for joining us here today. As I noted in the beginning, we will be sharing the slides and the recording with all of you who registered for this. We would love to continue the conversation and, of course, to do more webinars as we learn more. And hearing from all of you today has been really helpful. So thank you. Thank you, Jeff. Thank you, Juan. Thank you, Michelle. And we look forward to continuing the dialogue. Take care, everyone.
Thank you, everybody.
Thank you.
Thank you.